Hello, everyone, and welcome this evening. Please let us know if you're watching so I can see where you're coming from. Comment in the comments, and hello to everyone on the replay as well. I want to make sure that I'm seeing some faces before we proceed. I am Stephanie Taliaferro, representing the Hope for ATRT Foundation. Hope for ATRT is a research entity focused on directing research and resources to families in the fight against ATRT. And I just want to make sure that we're getting a good stream here. Okay, perfect. I'm getting some good signals. So thank you again for watching. We have a very special guest joining us this evening. Her name is Dr. Trisha Larkin. Dr. Trisha Larkin is dual board certified in pediatrics and pediatric hematology-oncology with an expertise in pediatric neuro-oncology. She serves as the Director of Pediatric Neuro-Oncology at St. Joseph's Children's Hospital here in Tampa, Florida. Dr. Larkin's career is dedicated towards expanding clinical growth, research, and clinical trial offerings for children battling central nervous system tumors. So I'm going to try to bring her on now. Thank you so much, Dr. Larkin, for joining us this evening.
Hi, good evening, Stephanie. Good evening, everyone who's joining.
Amazing. We're going to jump right into it because I've got a lot of questions and, our audience might have some as well. So let's just get right into it and learn a little bit about you. Let's start all the way at the beginning. What inspired you to become a pediatric neuro-oncologist?
Well, Steph, I think that's a really interesting question in this day and age. I think right now what we're doing in the world of pediatric neuro-oncology is very, very exciting. I would liken it to what happened with the leukemia community back in the 1960s and 70s. We historically had not the best outcomes with our pediatric brain and spine tumors, but in the past 10 years or so, we're really learning so much more about the molecular underpinnings of what makes these tumors happen. We've expanded our classification system, and we're really learning about what's driving these tumors, which is leading investigators and clinicians into pathways for different types of treatments that we would have previously never even thought about in the early days of pediatric oncology. Our patients population, of course, is just so unique. There's so many needs that these kids come across. And I found it's really just such a rewarding community to work with, being able to support these kids and these families during the horrific journeys that they find themselves on sometimes really has just been so rewarding.
Absolutely. Take us a little bit through maybe your journey of all the different amazing places that you've been working with and things that you've worked on.
Of course. So pediatric oncology has actually always been very close to my heart. I've been on the patient side of it, not for brain tumor world, but for one of our other diagnoses. So I kind of always knew that I wanted to go into oncology for kids. I started my journey really thinking that I was going to potentially go into more of the leukemia, lymphoma, and hematological malignancies portion of what we do. But in my hematology-oncology fellowship at the University of Florida, I worked in an immunotherapy lab with Dr. Dwayne Mitchell, who really has pioneered a lot of the vaccine therapies that we're using now for some of our pediatric brain tumors. And I just fell in love with the science of it. So following there, I spent some time at St. Jude, where I did a neuro-oncology fellowship, really focusing on clinical care and the ways that we can improve our clinical trial offerings for patients and really improve the quality of care that we're able to provide kids. So that ultimately is what led me into the neuro-oncology realm.
Wow. That's amazing. Anything else you'd like to share about your story before we move on?
So I'm a pediatric leukemia survivor. So that was really what brought me into oncology world. And, historically, we've come a long way with leukemia. We just haven't been able to quite do that with all of our brain and spine tumors. So I think right now, especially in the modern age, we have so much new technology, so many different modalities of treatment. We're learning so much more about truly what, again, drives these tumors at a molecular level. So it's really expanding our knowledge and the ways that we approach treatment overall.
Mm-hmm. Mm-hmm. Thank you so much. I think I'm seeing that more and more, where people who are, forced to be in this world see such a need and then want to make a difference in one way or the other. So thank you so much for the groundbreaking work, that you've been a part of up to this point. As far as Hope for ATRT is concerned, we are, mostly been more on the patient family side of things, the perspective of, the struggles with treatment, finding treatments, particularly treatments with relapse patients, things of that nature. But from a doctor's perspective, what are you finding some of the challenges are for treating children with brain tumors?
I think it's really navigating the community and finding the right resources within neuro-oncology. Neuro-oncology as a subspecialty in oncology is really fairly new. And I think what a lot of folks will find is that there isn't a huge community of doctors who focus strictly on brain and spine tumors. When we're talking about all the sort of basic science advances and clinical trial offerings, I think it can be very hard for a family who has a new diagnosis to receive all of the information that you've received right away. A lot of times our kids are presenting with very simple symptoms. They're presenting with headaches and nausea, vomiting. So families are finding themselves in community ERs, finding out that their child has a tumor, getting a lot of information about neurosurgical options. There's sort of this emergency rush. And what many of us who have been in the patient side know is you probably really retain very small amounts of that information that's given to you at once. From a physician standpoint, when you're delivering information, we want to be able to give everything that we know at the current time about your child to you in a concise manner. But very few of us have been on the other side, and very few of us understand that there's that small amount of information that actually kind of sinks in initially in the shock of learning what's happening. I think a huge challenge is once families go through that initial surgical resection, you see your child in a different manner. You see a lot of physical, speech, occupational type of deficits, and you're also trying to learn about the tumor. Sometimes there's a wait for pathology. You don't necessarily find out truly what the name of the tumors are right away. Right. And then clinical trials as a whole, the word trial is very scary. So trial for folks who are outside of the oncology realm, you think of experimental. And one of the things that I always encourage families to really acknowledge is without clinical trials, we can't move our field forward. Clinical trials in pediatric oncology are really designed to be the standard of care in a sense. So all of our clinical trials are looking at ways to improve the outcomes in terms of survival, but also in functional outcomes of children as we move forward into learning more about the tumors and learning more about treatments that we can offer. A lot of families don't know how to offer clinical trials or how to navigate the clinical trial space. So reaching out to organizations like Hope for ATRT, looking on the clinicaltrials.gov website, those are ways that you can kind of find out more about what's truly happening. These days, social media makes that a little easier too, because families can find more information out on things like Facebook groups. But really just, I think, initially absorbing all of the information that's given at a time. I think it's very important for families to realize that it's okay to pull out a sheet of paper and to write a question down. Something that does tend to happen is the doctor's in front of you and you can't think of anything, but the second we walk away, everything comes flooding to your mind. I always tell our patients, I will never be offended if they pull out a sheet of paper or pull out a note in their iPhone when we come into the room, because we don't necessarily know how much you guys know when you're coming into that situation. And repetition is key for a lot of our families. Sometimes having families just ask, what am I not asking that you think I should know, is a key question.
Yeah, that's the toughest for sure. That's really great advice, though, to not be afraid to take those notes and keep asking questions. That's really great advice. What are some promising advances that you're seeing right now? Something that maybe is exciting in the pediatric neuro-oncology world, brain tumor research that's going on right now?
So something that's happening right now, kind of on a grand scale, is really looking at molecular findings and methylation profiling of our tumors. So in a simple way, how to explain that is really looking at the minuscule genes and the mutations that are happening within those cells that are causing the tumors to occur. When we get to that level, we're able to identify different types of mutations. And one of the really exciting things about research now is we're identifying drugs and different immunotherapies and different targeted therapies that actually can pinpoint those mutations and essentially turn those switches off. I think something that has been wonderful in the past few years that the Children's Oncology Group has done is really introduce molecular profiling through their registry study for CNS tumors, or for central nervous system tumors. So if you're at an institution that is a part of Children's Oncology Group, I would definitely ask about that registry study to be able to get that information done from the tumor sample of your child.
And what exactly is that going to inform them, or more just you guys in terms of how to navigate the treatment, or what exactly is that going to be, kind of information is that giving them?
So what that molecular characterization initiative the Children's Oncology Group is doing is it is providing a detailed gene analysis of tumor tissue and also of non-tumor cells through a peripheral blood sample for different types of mutations that we know can occur in brain tumors and spine tumors as well. With that information, the clinical teams are potentially able to identify specific targeted medications that can either be used in combination with chemotherapy or as maintenance therapy for a lot of our tumors. The nice thing about being able to do that within the Children's Oncology Group registry study is patients are potentially benefiting from learning that information about their genetic makeup of their tumors, but we're also contributing that information to the general knowledge base about what really is driving our brain and spine tumors, which can help lead to more advances in clinical trials.
Absolutely. The more information that we can gather, absolutely. When we think about what's maybe coming down the line, I don't know if you have any insight into the future, or maybe just what you hope to see in the future. Maybe you could speak of maybe some things that would be some hopes for the future of brain tumor research.
So specifically looking at the information that we're learning with methylation, what a lot of our upcoming studies are introducing is more tailored treatment to your child's actual tumor. And whether that tailored treatment means ways to limit or even potentially eliminate radiation exposure, ways to introduce targeted therapies that help turn off the mutations that are driving these tumors, different ways to sort of reactivate any type of tumor suppression loss within the body. The knowledge that we're learning from all of this new molecular and methylation data is really helping us learn more about the tumors and ways that we could potentially approach them in the future.
That's awesome. That's exciting. But it also, in terms of ATRT, we always sort of say, no standard treatment of care. And unfortunately, that doesn't sound like we're heading in that direction, because that sounds very patient specific, which is good. But do you think that those two things will ever merge together in terms of a more standardized treatment? I hate to get off topic, but you know what I'm saying? Because we're personalizing it so much in terms of what we're seeing, do you think that eventually maybe we'll see more standardization of those certain things that we're seeing?
So in one sense, I would say standardization of treatment could be a really good thing. But on the other hand, it's very important for us to understand the different molecular subtypes of these tumors. So now what we know about ATRT through the past sort of 8 to 10 years of research is there's actually 3 different distinct subtypes of ATRT. And there's different gene mutations that actually drive, or different gene pathways that drive each of these different subtypes. Mm-hmm. So as we're learning more about these different subtypes, we might learn that the sort of sonic hedgehog type ATRT responds to treatment in a very different way than the MYC pathway ATRTs do. And what that does is that actually personalizes treatment in terms of potentially being able to allow us to reduce or restrict toxicities that we're introducing to one subgroup versus the other. So standardization as a whole, of course, is, when we think of standardization, we're thinking about kids in every different environment being able to receive the same treatment. But what we're actually learning about brain tumors is, even though they're classified as ATRT, they may actually act very differently. So that specialization or kind of customization of their therapies might actually end up being very important in helping improve survival, but also reducing toxicities of treatment.
Absolutely. Absolutely. Yes. Yeah, that's so good. Do you feel like, knowing now that we've kind of already branched into, ATRT specific information here, knowing those subtypes is really crucial? And
I do, because what we're learning now, and recently in recent years and recent studies, we're starting to see very promising agents. So things like tazemetostat coming out, alisertib, which is a aurora kinase inhibitor. But what we're also learning is there's certain subgroups that respond better to these drugs than others. Absolutely. So as we're learning more about these subgroups and we're able to study these things truly in clinical trial settings, we're able to learn more about which targets are really driving which pathways. Mm-hmm. So in a sense, it's personalized medicine.
Absolutely. Absolutely. That's so key. That's absolutely key. I know I kind of already jumped the gun on really talking about some ATRT treatments here, but just in terms of across the board, when you first hear that, someone's diagnosed with ATRT, what are some of those first things that you're thinking in terms of treatment options?
So the standard approach, of course, for all of our brain tumors is how can we utilize our neurosurgery team to remove as much of this tumor as possible in the safest way. What we have seen through the years of studying really all of the embryonal tumors, but specifically things like ATRT, is the goal of getting closest to a maximal safest resection really has shown some outcome in terms of survival. A lot of our studies are looking at different modalities of combining chemotherapy, different ways of delivering radiation, different dosing of radiation. So that standard backbone that we've approached a lot of our brain tumors with still definitely applies. Now, of course, with the newer information that we're learning with classification, is we can potentially introduce some of these newer drugs like the alisertib into improving what we're doing with the chemotherapy and radiation, and potentially and hopefully eventually limiting what we're doing with the toxicities of chemotherapy and radiation therapy.
Absolutely. Absolutely. We were speaking before the interview a little bit about, CAR T and things of that nature, and sort of the influx of options. Really, we're just trying anything at this point. What do you think about how that is being introduced and other options, different kinds of treatments available, different protocols, things of that nature that are just kind of, there's so many options out there right now that, our families are, really doing the research and seeing so many things. But in terms of just, for someone that may be not as aware, or someone joining on that's, a friend of a family that wants to kind of learn more, what would you just recommend in terms of how they're viewing that information, and where are some key places to be looking for treatment options?
So again, I would recommend not being scared of the word clinical trial. We find over and over and over again from a provider standpoint that the second a family hears the word trial or study, it's a very scary thought. But the way that these things are designed and the way that our studies are designed, there's different phases to those studies. So of course, the first sort of phase 1 studies really are looking at safety and feasibility. So is it safe to deliver these modalities, and can we actually do it as a medical provider and as a medical system? But once we start getting really into those phase 1, 2 studies that are looking at efficacy, the goal of these things is to look at these treatment options in a standardized way so that we protect the safety of the kids while also moving forward treatment. When we're looking at clinical trials, again, our community organizations, so places like Hope for ATRT are amazing resources for finding out more about what's truly available. Really reaching out to the larger consortiums in this country. So we have Children's Oncology Group here. We have PNOC, which is the Pacific Pediatric Neuro-Oncology Consortium. We have the PBTC consortium in the country. And then, of course, we have the NIH clinicaltrials.gov website. So really starting at those kind of tried and true modalities and tried and true systems to look up clinical trials. And just asking the right questions. There's never a dumb or stupid question in dealing with oncology. There's only things to learn. The other kind of caveat that I always like to tell parents as well is the diagnoses that we treat are very rare. So in order to be able to collect enough data to really publish papers on cohorts of children who have been treated with different modalities, sometimes those papers take us a very long time to get out. So sometimes what you're reading online may look very, very scary in your basic Google search, but what you're reading online might be what was considered standard of care 10 years ago, or what we were doing 10 years ago. So really reaching out to sort of the central bodies that really focus on pediatric cancer, and connecting with folks through those areas is really important. The other kind of thing that I had alluded to earlier in the talk is pediatric neuro-oncology is a very new kind of world and subspecialty in a sense. There's definitely folks around who have been doing it for a very, very long time, but the actual kind of dedication to those areas you find fewer providers that are dedicated solely to taking care of kids who have brain and spine tumors and who are dedicated to finding out the research. Organizations like, those at St. Jude, Boston Children's, Texas Children's, they have ways that families can submit for second opinion consults. Places like Hope for ATRT also have networks of providers that they can reach out to help get families information.
Absolutely. That's a great thing that you brought up. Some parts of even, this country, the physicians aren't familiar. It is still a very rare diagnosis, and sometimes they are not sure the best, course of treatment. We've actually had on 1 or 2 occasions where, families have reached out to us to say, what can I bring back to my doctor? And in that case, when people aren't maybe as close to a facility, what are some of those things you might recommend in terms of making those connections with maybe a larger, hospital or facility that is more, treating more patients or more familiar with the diagnosis?
So again, a lot of these hospitals have networks through where you can go on their websites and you can submit second opinion consultations. I also think it's very important to have an open conversation with your provider wherever you may be. I know when I initially transitioned from a setting like St. Jude to a more community-based hospital here in Tampa at St. Joseph's, I actually encourage families to reach out and get second opinions. And I've had a lot of families tell me, oh, that's really odd that you do that. But one of the wonderful things about being a part of the pediatric neuro-oncology world is you'll find that so many of us are connected.
Mm-hmm.
There's so many of us who have worked together in different parts of our careers or who participate in different research consortiums together. So if there's someone in the country that you want to get an opinion from, there's a good chance that your local oncologist knows that person or knows someone who knows that person.
Okay.
So I always encourage just to ask, be very open with your provider. Know the background of your provider as well, because again, pediatric neuro-oncology it's a small world in a sense. Like sometimes when you're in it, it doesn't feel that small, but we a lot of us know each other. And there's a good chance if I had a patient who, for instance, said that they wanted to get an opinion from, of course, somewhere like St. Jude where I've worked, but also, the Children's Hospital in DC, I have a phone number for that person.
Mm-hmm.
So just open communication with your local treating physician is so important.
Absolutely. That's great. It's great information.
Stephanie, actually, one other thing. So a lot of families will meet the neurosurgeons off the bat. That's just kind of how, our kids present in the ER, which a lot of, folks on this chat may have had that experience. I would be very open, and if there's a concern about a tumor, I would ask the neurosurgeon if there is an oncologist on staff that they could potentially talk to. One of the things that we've done here in Tampa is the second suspicion for a brain tumor walks through the ER or walks into a clinic and our neurosurgeons are notified, I or my team gets a message or a text about that patient so that we can meet with the families even before surgery to sort of talk to them about, what happens with surgery from a medical standpoint. Where's that information going? Potentially who else might be reviewing your pathology and what other testing possibilities may be out there.
That's another great tip. Absolutely. Absolutely. Kind of taking a step back, for anyone on, watching this video, this is kind of a fun question, but, when we talk about ATRT, we always just say ATRT, but, ATRT stands for something. And so what makes ATRT ATRT? What are the defining characteristics? Can you kind of break down each of those components and kind of explain what those letters mean?
Sure. So A is for atypical, T is for teratoid, R is for rhabdoid, and T is for tumor. So what ATRT as an acronym really refers to is what the cells look like under a microscope. So these tumors are poorly differentiated rhabdoid cell tumors, and usually they're characterized by a mutation in either a SMARCB1 gene or a SMARCA4 gene. And these tumors are considered to be highly malignant. When we talk about brain tumor classification, we use the World Health Organization classification, which goes from grade 1, which is really more benign tumors, to grade 4, which is really more malignant and aggressive tumors. So ATRT falls within the grade 4 category. It is our most common malignant brain tumor that we see in children younger than 6 months of age. And usually about 2/3 of the kids affected by it are less than 3 years old.
Wow. Thank you. How how do you stay, this is a question that I didn't have prepared for you, but how do you stay up to date? I asked you this earlier in the information. How do you, we try to stay up to date as Hope for ATRT, but as a physician, what are the ways that you are staying up to date with the advances, with the research that's out there?
So, you're constantly reading and you're constantly learning. One of the biggest parts about being an oncologist, I think, as a whole, is really being a sponge and absorbing everything else around you. Like I mentioned before, the Neuro-Oncology network is very small in a sense. So we have multiple research meetings throughout the year. We have a lot of different conferences throughout the year. We stay in touch with what's happening in the bench side of the research world as well. So our science and our trials and our treatment options have to go from the very basics of even preclinical animal models into our phase 1 studies and then our larger kind of phase 2 to phase 4 type studies. So a lot of us who practice neuro-oncology are really keeping up with the basic science part of it. And we're seeing the very basics of our laboratory benches and our preclinical models kind of being evolved through the years and introduced into clinical studies.
Awesome. So important. And then I'm going to ask also, what are some of the most rewarding aspects of your work? And then couple that with some of the most difficult aspects of your work.
So I would say by far, as a pediatric neuro-oncologist, the most rewarding part of my work is really educating families. Mm-hmm. So one of the things that I tell families from the get-go is I want you to understand your child's diagnosis as much as I do. Mm-hmm. So if that means breaking it down into very simple acronyms, if that means drawing pictures, even though I'm not an artist, for them so that they understand treatment, at the end of the day, I truly believe that families should be empowered to have the knowledge that their physicians have about their tumors. Mm-hmm. Of course, the most rewarding thing is being able to celebrate that end of therapy and being able to see that kid do well. One of my special interests specifically is in reducing toxicities that we see related to treatment. So when I have a patient who has gone from maybe having something like a posterior fossa syndrome after surgery to being able to resume school and participate in our community activities and resume normal life, that by far is the most rewarding and just powerful thing to me. Mm-hmm. Challenging piece, of course, is that we haven't always had the best outcomes in pediatric neuro-oncology, and there's still some diagnoses that we don't. ATRT has been a challenging one, but thankfully we are moving ahead with our advances, and we're doing better and better each year and how these kids are doing, and with each study and each trial and each new modality of treatment. But sometimes we don't have those happy stories. And what, as a field, we're really hoping to do is advance the science and improve our treatments so that we do have more of those happy stories at the end of the day.
Absolutely. Absolutely. And last, we always like to close with some advice. You've already been giving a ton of advice to our families throughout the interview, but if there's anything else that you would like to share in terms of advice to give to parents of children with brain tumors.
Just open communication. Do not be scared to ask your questions. Do not think that your medical team's going to think a certain way of you if you ask about a certain supplement or a certain thing that you've read online. We really would love to have open communication with all of our patients and all of our families. Our job at the end of the day is to support you through this journey and to educate as much as we can. So never, ever, ever be scared to ask those questions, or be able to just ask, what am I not asking?
Mm-hmm. Yeah, that's a great question, because you just don't know. And sometimes you're just in it and you're not sure. And that is a great, great, great question to remember. So thank you so much, Dr. Larkin, for joining us this evening. Our time flew by, but you've given us so much good information to kind of chew on and to remember. So I want to thank you from all of us for sharing this evening. And to all of us watching or us on the replay, please, if you have questions, don't hesitate to email us or to write in the comments. I might not be seeing all the comments, so I apologize. We will be sure to get back with any questions that you guys have. And also, if you're a family that's not currently connected with us, please go on our website, hopeforATRT.org/getconnected, and fill out our connection form. We'd love to get to know you and connect with you. So, or if you have any other questions, you can email us or go on our website to learn more, like she said, about trials, resources that are available. That's what we're here for. So thank you all again for joining us. Thank you, Dr. Larkin, and have a great evening. Bye, everybody.